as well, and Ming is chuckling here. Let's make sure we're not out.
Yeah, exactly.
So this may be familiar to all of you in the room. A child, and for many who've experienced this, who is a perfectly healthy child who comes in at 3. And I heard some stories, and Kim's story and the other stories I heard are so familiar to us as pediatric neurologists. Coming to the emergency room, leaving, saying it was just a flu, just a cold, and then coming in with something very neurologically, I would say, extreme. Developing an upper respiratory tract infection, and then a few days later, developing difficulty walking and irritability. Now, at Sick Kids, the institution where I work, people are fairly rapid. I work in a very large urban center, and people are, unlike some of the stories I've heard, people are fairly rapid in identifying and getting neurologists involved and getting MRI scans. So I understand this is not the experience of everyone in the room, but in our situation, a child might come in with this kind of MRI scan. Now, I'm so glad we had all of the introductions, so I understand where everyone is in terms of imaging. And I also understand that you guys have been living this for quite some time, and you can probably identify the abnormalities here without the arrows. But I want to tell you that not everybody recognizes this, but this is a very typical appearance of what might be seen. And often what happens is that, can you hear me? Yeah. Is that when someone sees something like this, they'll call me immediately. They'll say, they'll text me or whatever, they'll WhatsApp me, they'll hypercare me and say, hey, listen, whatever time it is, we've got this, can you help us out? Because what you see here is the prototypical appearance of what we see as doctors, and that's the bi-thalamic, so on both sides of thalamus. And anyone that is not following this, I'm happy to go through this. And can I just ask you, when your doctors got your MRI scans, how many of you were able to go through the scans carefully with your doctor to and the doctor actually helped you to understand where the problem was? Yeah. Okay, very good. So some people, most people, and it's interesting, as time has gone on, people have become more and more comfortable with having that. Sometimes for us physicians, we always ask if people want to see, and not everybody wants to see right at the beginning. And then what is everyone in the room is most familiar with is that when you use a certain sequence that brings out blood, you'll see the very typical images. Again, the 2 black areas are the areas of hemorrhage, of bleeding that occur and in a situation where what I believe is a secondary, meaning that occurs after there's been massive swelling. Okay? And really, the idea is to get on top of things before this happens, right? Before the bleeding happens. So, to address the question of the diagnosis, one of the things that and we were actually talking earlier about this, the concept of the genetic diagnosis, but the fact that the genetic diagnosis is only a part of the puzzle, and this is something that we did for a chapter we wrote on ANEC, where as a medical observer and medical evaluator, we deal with all kinds of things, and what we deal with is infectious complications that lead to neurologic issues. And what we see is that there are influenza-associated encephalopathies, which intersect with the genetic diagnosis, but are not exclusive to the presentation of acute necrotizing encephalopathy, encephalitis of childhood. And that Ming is going to be talking about what I've been tasked with is sort of diagnostics, but Ming is going to be talking about this sort of overlap here between these two, right? Where some people may have the mutation and some people may not have the mutation. But from the other side of things and from the clinical side of things, and this year, I mean, I heard a story about someone whose child was affected. This year was a particular influenza strain. There was a particular influenza strain that brought out more ANEC. And I know that from the Canadian experience because we have a Canada-wide sort of communication network where it was actually raised within our own hospitals that people were seeing a lot of it. So definitions are things that are made to be broken and moved forward because, but I put this slide up, and these are the official definitions, or the ones from the individuals who first described them. So if you think about this, was first described in 1997, and to me that was not that many years ago. We were talking about actually Vanessa and I were talking about when we were in Montreal, and that was around the time when we were in Montreal, and we're very young people, okay? And so in my lifetime, this has been described. And then further to that, that was when we started getting a lot of MRI scans. But then the work of Derek, who's not here today, but was mentioned, led to the identification of a particular genetic mutation. And in fact, and also listening to Kim this morning really brought back, and others this morning, brought back memories of when I first learned about this disorder, and about the genetic mutation. We're fortunate to have genetics counselors within our institution that helped me to learn about it very soon after the gene was diagnosed, the gene was identified. So I put this up there because I want to come back to it later so that we can talk more about how we define things. Now, clinical features, everyone is very aware of this. I don't think I need to tell you. You need to tell us, in fact. And so, and why I put this up is that in our institution, we've followed 20 to 25 children with this disorder and more now. But what we did was we looked at what the kids came with, and what I want to identify is that in the first definitions, people were trying to figure out what this was, and they said you absolutely can't have white blood cells in your cerebrospinal fluid, which to all of us that do neuroinflammation think, what? But that's the defining feature of what neuroinflammation is. We think this is an inflammatory process or a secondary inflammatory process. And so really, some kids will have elevated inflammatory markers, but not all. And I will tell you that Alex Palazzo and I have had many discussions about the significance of that, and Theo as well. And at least half will have elevated white blood cells in the cerebrospinal fluid, which is important because in order to get the bottom of this, we need to understand if this is an immune pathway that's being driving this, or if it's that the endothelial, the skin cells, are the part that are abnormal. And we'll hear a lot more about that because of where the REBBP2 gene affects. I just want to emphasize here that as many of you are aware, the most common thing that we see within our practice is that influenza, and in particular influenza A, can be associated with this. And I know that we'll be talking more, and there may be some questions about prophylaxis and prevention. And I think that we should talk about that as a group because, again, we need to come up with a standard that every family feels comfortable that they can share with their practitioners due to the rarity of this phenomenon and the potential lack of support really around the world, because it doesn't always happen in Toronto or in London or in Amsterdam. And most of the time, most of you are not from large urban centers. So this is something that we need to help to come up with you. Okay. Now, treatment is something that we'll talk about a little bit more later, but I heard a lot of discussion about, you know, variations and outcomes, and again, highlighting things that Kim said, that Jared said about their family members, about how some kids seem to be affected and some kids seem to come out very well, and then some have outcomes that are not as positive. In our own institution, we take a very assertive anti-inflammatory approach, such that kids are usually treated when they roll in the door. If they have, because we get a scan very quickly, we get an MRI scan. If a child with a known history or gene mutation comes up, we have a protocol in place. But if there is a child who comes in with a new type of encephalopathy that is recognized by the emergency room physician, our emergency room physicians are very fast to get MRI scans, and then we have a cascade that hopefully happens relatively quickly. And on that list are steroids. For this particular condition, we choose to use plasma exchange or plasmapheresis over IVIG because we think it works more rapidly. How many of you have the experience of having your child or your family member receive plasmapheresis? A couple of people. Okay, not a whole lot of people. And then the other kid on the block is something called IL-6 inhibition, tocilizumab, and there are other forms of blockade of a particular inflammatory molecule, a cytokine called interleukin-6, which some of you who have family members who are more recently affected might have received in combination either with IV immunoglobulin or steroids. Because we know the history of A&E in our institution, when we see something like that, we tend to start with steroids, but go very quickly to plasmapheresis within a few days. This is just it's busy, but I just want to let you know that there are people that are really thinking about this and putting together all the cases around the world. And this is from one particular review of all of the individuals that have been published, whose experiences had been published, looking at the possible effect of early steroids versus later steroids, and early steroids plus IVIG, early steroids plus tocilizumab, IL-6 inhibition, and then plasmapheresis. And the thing I want to highlight here is this last. Can you see my mouse? I don't want to head here, but I understand we have a neurologist in the house that can help me. A neurologist or two. If you look right here, this is the one I want to identify for you. This is plasma exchange, and we heard the stories of some families who have lost children here, and it's heartbreaking for us as physicians to hear that. And so we really are sad for your loss. What this particular graph identifies is that the survival with plasmapheresis is almost 100% in published cases. And so I'm a real advocate when we have a highly inflammatory condition, especially one that involves the brainstem. Not all cases include the brainstem, especially when it involves the brainstem of treating aggressively with plasmapheresis and plasma exchange. And the other bottom line here is, and again, this is going to be brought up in the question and answer, I understand, is that question of early treatment. How do we get to kids as early as we can? Right? Okay. I'm just going to do a couple of slides on the past and now, and this is from a review of the literature that had been done, I think in 2022 or 2023 by Ben Casson at Hopkins. And what they did was they looked at the outcomes using a standard scale called the modified Rankin scale, where that evaluates, it's a very rough scale, 0, 1, 2, 3, 4, 5, 6, where the higher number is it identifies your ability to do things in everyday life. And what you see is a predilection in the literature, and there may be a bias within published literature that people publish what are the worst case scenarios, but that in the past, really, there were a large group of people that did very well, but also there's the other end where there were large groups of kids that had poor outcomes. We think that that's changed, at least based on our experiences in Toronto. And we find that there is excellent motor recovery in most of the kids we're taking care of. And you in the room are witness are demonstrations of the fact that there can be and there is very good recovery. We still don't have the answer to why, who, but we did look at a couple of questions. And one of the questions we looked at was, what were the things that drove better outcomes? And what we found, we looked mostly at MRI scans. And what we found was that the severity at onset didn't matter so much as the involvement of the pons of the brainstem. And it makes sense from a neurologic standpoint that if you have brainstem involvement, then your likelihood of having a favorable recovery, we use the modified Rankin scale as well, of less than 2 is going to be lower. Okay, and again, from a neurologist perspective, whenever we see a lot of inflammation or swelling in the pons, it makes us doubly or triply attentive to being able to treat. Kim.
So I just want to ask a question.
Yes, can I have you say it into the microphones just so for the people?
So when you're saying you're seeing better outcomes, what would be the percentage of genetic versus non-genetic in those better outcomes?
Yeah, so we found a difference in outcomes with genetic versus non-genetic. We had about 40% of our group had were RAMBP positive, and 60% were not. And we didn't see a difference in those outcomes. But again, what I want to highlight, and many in the room will attest to this, is it's not necessarily the first episode, right? When you have multiple episodes, it's as in the other things we take care of within neuroinflammation, you have multiple episodes, multiple hits will lead to a change in outcomes. Does that make sense, Kim?
Yeah, definitely.
Okay. I'm gonna just wrap up with this, because this is something that we were talking about, and the question is, and the fact that we have so many of you here today that have family histories, families with the gene or other relatives that may have had complications. And the question that I bring up again is, from this side, if you've got the mutation, what happens, right? Not from up here, which is what Ming's going to talk about, but for the next 8 seconds, I'm going to just mention this because the families that I take care of made me ask the question of why it is that even if you're positive for the gene, not everybody gets ANEC. And in fact, recently we had a child with the diagnosis, and digging in family history, the most common thing that we've seen in kids is a history of seizures, but not difficult to control seizures in the family. And maybe other neurologic manifestations. And so the reason I'm sort of bringing this up is because, and people may be talking a little bit more about this, is that while the focus in our MRIs are on the thalamus and in the pons, it's possible that there's a broader there are broader areas that may be affected silently. And I happen to have a patient, a family, with a child that came in with RAND-BP2, and the mother said to me, "Oh, you know, I have a daughter who also has been seeing a neurologist. Fancy that." And I said, "Well, that's strange, right?" Wouldn't expect that. The child was a little bit older. And in my clinic, we focus very much on the eyes, and we check everyone's eyes very carefully. We use a machine to look at the back of the eyes. And she said, "Oh, she has seizures, she's got some learning things going on." Oh, okay, we better check her for the gene. We do that anyway. But then my tech came in and said to me, "What's going on with her eyes?" Right? And what I found was that that she had mild retinal abnormalities that would not be seen by most people, but I have a machine that's kind of high tech. And it demonstrated that there were some retinal abnormalities in the background. And so I actually, I didn't know that this was a possibility, so I talked to our genetic ophthalmologist, and in fact, our animal models suggested maybe retinal abnormalities associated with RAND-BP2. And I'm not saying this to scare anyone, because vision is fine, but it may be a window to understanding what's going on and to helping us to understand the processes. Because if you look at the numbers, the normal number should be 100. And her numbers were about 25% to 30% down, and in two areas that are of significance. That was the child's, and then this is the sibling, who had even more affected eyes. And had seizures for a number of years. Okay. So I thought, well, maybe this is a one-off. But then I started looking at the eyes in other families. And more recently, I had a child who received the diagnosis. The family came in, got a family history of seizures in the father, and I asked him if I could look inside his eyes. And he had the same findings. Okay. So I think it gives us a clue, and I don't think this up. It's not that it's the eye, but that the process is probably something that we can learn about in every part of the brain and not just the thalamus and the brainstem. I'm going to wrap it up by asking the question of, do we need to revise criteria? And do we need to talk more as a group? Which I'm so glad that me and Natalie organized this. To talk as a group and say, okay, what are we going to do together? And how are we going to think together? Because we shouldn't all be doing different things. We shouldn't all be calling this something when the evidence tells us that, you know, certain rules may not be true. That's it. Okay, I'm happy to answer any questions. And I thank you all for your participation.
Is there any questions right now? Raise your hand and I'll pass the mic around.
Just to come back to those retinal lesions, is that during a seizure or is that?
No. All right. Let me, do you want me to explain this a little further? So, and Ming and I are actually not on this disorder, but Ming and I are working on a paper right now about retinal abnormalities and the evaluation of retinal abnormalities. So one thing that we all know is the eye is a window to the brain. And what we've learned, a lot of the work that I do is in multiple sclerosis. And I've been fortunate enough to have been tweaked to the knowledge that the eye is a really good way to learn about stuff. And to learn about processes that are going on in the brain in a very easy way to access things. These are changes that are not acute, naturally. They're chronic changes. And I'm not sure when they happen, but what we know, and I think this is something that we can learn, maybe learn from all of you if you're willing to help us to learn this. What we know that in the other things that I take care of, there can be acute problems, but then there can be slow changes through time. And what I think this is a demonstration of some slow changes that may have occurred, or an early kind of event, but not a chronic event.
My question was about the eyes as well. So there's been significant visual disruption post ANE episodes in our children where they go completely blind and then it's somewhat restored to a certain level post, and our oldest daughter has hallucination, visual, not mental hallucination, but visual Charles Bonnet syndrome. So I'm just wondering about whether there is also that connection in that regard as well.
Yeah, maybe. And so what you're referring to, there are a couple of possibilities from the perspective of a neurologist. And so neurologists, you don't need to learn this from me, but I'm saying this wrong apparently. And so the vision comes from many different places, right? It comes from the eyeball. Like if you get hit in the eye with a ball and your eyeball gets damaged, and you can have visual problems. And then if you're the back of your eye, which is the pathway to all of the visual signals going to the back of your head, you can have problems as well. And your nerve can also be affected. But finally, that pathway is super important for relaying messages. And so I don't know where along the pathway your child's vision might have been affected. One of the things that we could think about is to ask the question, well, is it what we see sometimes is that when the area in the back of the head called the visual cortex is affected, people can't see. And then or anywhere along the pathway in the brain becomes affected, there is we call it retrograde, but there is a secondary effect, an effect from that injury to the front of the eye from that injury. So I'm happy to talk with you more later on about this, because it's very interesting to me that you report repeated episodes of visual loss, because one of the things I do a lot of is to ask questions about why the nerve becomes inflamed. And so is it the nerve that became inflamed? And could we learn something from what has happened with your children? Yes.
So, thank you, because I mean, learning from the eye is of course something indeed that tells you about neurological disease, like for instance also in TREX 1, and other genetic
I don't think
disease.
your mic's on. You want to make sure just so that people can push the bottom. Is it on? Okay. Yeah.
Well, seems to work, but sometimes not.
Yeah.
So there is a lot to learn, of course, from the eye, as you already mentioned. Is this always bilateral? So both eyes are affected, or might it even be one-sided?
Well, so this is what we need to learn as a group. And actually, when I was corresponding with Natalie about this, I said, "Is anyone going to be mentioning retinal abnormalities?" She said, "No, why?" In her email back. So we don't know the answer to this in this particular group, right? Every person that I've looked at has, it's on both sides and it's mild. So when one looks with an ophthalmoscope, you guys have doctors that use that machine with the light on it, the ophthalmoscope, to look at the back of the eye. When you look, most people would say, "Oh, that looks okay." It's the machine that I use that helps me to understand the gradations of atrophy.
Another question relates to the plasma exchange.
Yes.
So the time lapse between onset and starting of the exchange, does it matter to a certain extent? So what's the experience? Should you start right away? Because in our hospital, I'm sure you have to convince a lot of people for the anesthesia, for whatever.
Yeah, for getting the line. It's basically the line. Yeah.
The ICU is already full,
So, I don't know the answer to that. I don't know the answer to that, and plasmapheresis access is something that is challenging in a lot of institutions. And so for that reason, I'm not going to say that everybody should be starting at the first, but we should talk as a group. Because if we as a group say, listen, look at the results, what seems to work, and we can look at, we can pool all the information we have from around the world and say, well, what happens when we start it later? I will tell you, it's going to be very, very hard to identify the perfect time, because we've thought about this in many other disorders. I think we've tried to do trial on IVIG and trouble, and so it's very, very hard, but our alternative is to say, well, it seems to make a difference. When do we want to start as a group? When do we agree is a reasonable time to start?
Yeah, we have one on the screen behind you.
Oh,
from
sorry.
Andrew.
How, extra good bacteria against the influenza, not getting ANE in there. So I don't know, and I think the ID folks can address this with much greater detail than I can, but I think the bottom line about combating viruses with bacteria doesn't work in the acute setting. I mean, by the time you know that you have influenza, that virus is all over the place, and so and it's acting too quickly. And really, what we think is that it's not the acute infection, but the secondary effect of having had the infection. A lot of the kids, and you guys will all attest to this, will say, oh, we had a little bit of infection on swab, and they'll say, oh, influenza positive. And that's the only reason we know there's an association, not because they were especially sick with influenza.
I have a question about also plasmapheresis.
Yes.
It is true that probably this is the therapy that in acute stage is used less from the centers. I mean,
Yes.
it is mostly used steroids and immunoglobulins also because it is easier to use.
Yeah.
But also because this is thought as not an antibody-mediated disease, and we know that usually
Yes.
plasma exchange is used basically mostly for the antibody-mediated disease. I mean, then there is also the problem, I think, of the publication bias. I mean, most of these, usually if you have success with something, you are you publish it, but if you don't have success,
Absolutely.
so we have to be careful to the interpretation of data, and so it is very
Totally agree.
interesting. It is very important that there is this connection, that the data will be collected in a more scientifically clean way. And my question was, plasmapheresis, what do you think about the mechanism of action? It could be the clearance of cytokines or humoral clearance or what?
So I'm actually, I think that's a really important question, because when I first started in this business, I really thought plasmapheresis was only for antibody-mediated conditions. And when I said, why are I asked the same questions? But what I noticed was that in kids that had spiking fevers due to cytokine storm and things like that, that plasmapheresis was very effective in getting that down. So I really feel that the plasmapheresis has a broad immunosuppressive effect in terms of actually getting the cytokines down. Now, how, it's not the filter that's doing it, obviously. The filter's getting antibodies out, but I think it's got a powerful, broad anti-inflammatory effect, and that's why we try to use it, even if there's no antibody, even if there's no antibody involved. But again, I think it's very, very important to be not be dogmatic, about our decision making. Just because everyone's doing plasmapheresis doesn't mean it's the right thing to do, and that's why it's so important for us to say, okay, well, maybe some people will do it and some people won't do it, and we'll see if the outcomes are any different. Okay? Because we don't know the answer.
So it is important to understand here what it means exactly, because it is important. It is more standardized when to use it, maybe before immunoglobulins. So anyway, it's very interesting.
Yes, we don't, and these are things that we don't have the answers to. I don't want to take up too much time. But it's good that we're having lots of discussion. We do have time? Okay. Okay, let's go then.
And very inspiring talk. So I'm interested in that when you follow up with Kim's question, when you say there are 40% positive for ROM2. So I want to know how is that defined? So there are major first one, right? The major one or the major three, but CLIPA also has other mutations as well. So I'm wondering, I suspect it's single sequencing for ROM2, right?
Yeah,
When you say positive, is it limited to those few major common sites, or like you don't see any mutations on the ROM2 at all?
So what we do is we actually send to, I think Blueprint is the place we send now for ROM2 testing. They test for the common mutations, and then we request a exome afterwards if they're not positive. And so we'll say in that particular evaluation, we did not have exomes on everybody. I think the other thing that is very clear to me is that the only kids that have recurrences were the ones that were positive for mutation through the genetic testing we sent.
Okay, so the positive does more clearly with the recurrent.
The positive mutation, yes, but we don't have any. Well, we have a couple of kids. So there are some situations where an initial diagnosis of ANEC is associated with things like a condition called HLH, and with unknown genetic condition that we've been searching for, and other reasons. We've had recurrences in some children that are not ROM2 positive, but then they've ended up with systemic things. So I think the clue to the thing for clinicians, if you're practicing, is always keep your mind open. If the gene is negative, but you've got systemic stuff, look for HLH. That's an important clinical lesson. Look for HLH, for immune dysregulation, and consider involving your genetics colleagues for exome or genome testing.
One more here.
Just one last and then have a longer line. Sorry, Kim. I've got so many questions.
But there's going to be a
Thank you for the great talk. I have a question that I always wanted to ask a group of immunologists, and that is what makes influenza as a virus typical, or what is so typical is the interplay with the influenza and the immune system, and what are your thoughts about maybe what it can learn us about the underlying disease mechanism? Yeah.
I think this is something that we need to, as a group, learn.
I took from your neighbor.
I asked you already. But it's such a common infection, and there's probably a lot of reasons.
But I mean, think about this, okay? For the neurologists in the room, the others in the room, think about this. And we were just chatting about this. This year was a very big influenza year, and it was a big ANEC year. This year was also a very big mycoplasma year, and we had more mycoplasma-related neuroinflammation than I've seen in my career in one year. We had like 15 to 20 cases like this. Okay, and so I think that we as a group need to learn what that gene-environment interaction is, because there's always a gene environment interaction. And so I don't know the answer to it, but it is, and Alex Palazzo, who's not here today, you know, I said to him, he was very interested in IL-6. I said, well, what is it? I asked your question. I said, what? I care about IL-6, but I care about influenza because why? Why is it then that we have a big influenza year and we have a big influenza? Thank you. I'm sorry I took so much time. Yeah.
Okay, so I've got a few in, I'm sorry.
That's okay. Why are you apologizing?
Going back to the retinal, we see in the group a huge percentage have vision issues.
Okay. Mm-hmm.
Do you see that as well? That's part one.
So we were actually talking about this at dinner last night, and so there can be such a variety of vision issues. I think one thing we need to do as a group, within my own, the kids that I take care of, I look at every back of everyone's eyes, and so when the mutation seems to be positive, there seem to be retinal abnormalities, but those don't manifest as significant vision problems in terms of everyday life. Okay, so I think a question that we can ask as a group, and maybe we can figure out a way to really round up the information, is what are the vision problems people are experiencing if it's a high percentage? Some of it could be related to those visual pathways. Some of it could be related to the eye movements, which become very involved when you have a abnormality in the pons. Well, right next to the pons are the areas that control eye movements, right? And they're very and in the pons. Is the control of eye movement. So it could be that. So first we need to catalog what people are talking
about. So going on from the sibling that presented that hadn't had an ANE episode, apart from the seizures, what does those retinal damage, what does it look like to them, to that child? Were they having other vision issues, or did you just pick it up?
I picked it up because that's what I do. Okay. Yeah, and so that's why I'm saying there's so much that we don't know, but that we could learn from, because we don't have the opportunity to look really carefully and ask the questions.
All right, I've got a few more, but I'll leave it at that.
Okay, thank you. Thank you so much for those questions. They were great.